presenter is Dr. Adham Alauddin. Dr. Adham is a pathology resident at Children's Cancer Hospital in Egypt. His presentation is entitled The Great Masquerade, a Renal Mass Mimicking Wilms Tumor. His case is under supervision of Dr. Dua Hassan Salim, a pathology consultant at Children's Cancer Hospital, Egypt. Dr. Adham, are you with us?
Good evening, Dr. Muhammad. Can you hear me?
I can hear you, doctor. You can start sharing.
Okay. Is it visible?
Okay. Yes, I can see your screen. You may go on and slideshow start. Okay.
Okay. Good afternoon. Good afternoon. First of all, I'd like to thank Dr. Muhammad Kamal and Shefa and everyone at Shefa Al-Orman Hospital for this amazing and fruitful event. And I'd like to thank you for the invitation. Okay. Our case is a 12-year-old female who presented to our institution with abdominal pain and distension for 2 months. She had no history of hematuria, and her baseline complete blood count, liver function, and kidney function tests were all unremarkable. An abdominal CT was performed, which showed a right polar renal mass measuring 12.1 by 10.8 by 7.6 centimeters, stretching the right renal vessels at the hilum, and the radiological opinion was that it's most likely Wilms tumor for histopathological confirmation. We can see here an axial cut, and this is the coronal section, and we obviously see the right upper polar mass. So the multidisciplinary team's decision was to perform an upfront radical nephrectomy, as it was decided that our patient was not an ideal candidate for chemotherapy. We received at our grossing room this right radical nephrectomy specimen weighing 660 grams, measuring 16.5 by 10 by 6 centimeters, with an attached ureteric segment measuring 5.5 centimeter long. Opening of the specimen revealed an upper polar mass measuring 12 by 8.8 by 4 centimeters with a rubbery, glistening grayish-white cut section. Okay, onto the microscopic examination. So, if we consider this, if we consider our first possible diagnosis to be a Wilms tumor, then we typically expect a triphasic tumor formed of a blastomal component, an epithelial component, and a mesenchymal component. However, the initial screening of our specimen, the microscopic slides, revealed a mildly anaplastic, mildly pleomorphic spindle cell proliferation, which had these occasional large cells that had abundant eosinophilic cytoplasm, eccentric nuclei, and some prominent nuclei. We can see here a similar picture, but with focally edematous stroma. And so at this stage, we are thinking perhaps this is a dominant mesenchymal component of Wilms tumor. As we can see here, this is another good example of these large cells with abundant eosinophilic cytoplasm. And so we try to interpret these as an example of rhabdomyogenic differentiation in the mesenchymal component. However, as with every good pathologist, a sense of suspicion began to arise. What if this is not an actual Wilms tumor? We can see further sections here. We can see that the mass infiltrates into the renal parenchyma. It infiltrates into the renal sinus fat. And it infiltrates into the adjacent suprarenal gland as well. This is actually a hilar lymph node, and we can see that the hilar lymph node is almost totally infiltrated by our tumor. This is another hilar lymph node with just a remnant of minimal remnants of lymphoid tissue. At this stage, we revised the patient's data and we ascertained that the patient received no therapy prior to resection. So the image that we are seeing currently is not any evidence of therapy effect. And so we felt a bit stuck. And so as with any vagabond cell that does not reveal its identity right away, we obviously resort to immunohistochemistry. Desmin was negative for the spindle cells and for these large cells with abundant eosinophilic cytoplasm. However, S100 was diffusely positive, and it was diffusely positive in both components. As we can see here, these are lymphoid aggregates that were found within the mesenchymal component, query mesenchymal component, and the tumor as well was also positive for synaptophysin, and it highlights these large cells quite well here. Okay, so in order to reach a diagnosis in the near future, we had to go back to our first step. So back to the dressing room we went for further sampling of the tumor. And while revising the photography from the initial dressing, we can notice in the upper peripheral pole here, the tiniest tinge of a yellow-orange tinge, which could be a distinct clue to what this tumor really is. I'll show you further additional sections that were submitted from the mass. First of all, by low power, it was clearly evident that there is a nodular pattern to our tumor. And further sectioning revealed that these cells that we were suspicious of as an example of rhabdomyogenic differentiation were actually ganglion cells at different various stages of maturation. Again, ganglion cells and actually Schwannian stroma with lymphocytic infiltration in our tumor sections. So our diagnosis is actually a ganglion neuroblastoma with dissected hilar lymph nodes that were positive for tumor metastasis with total maturation and extracapsular extension. One final piece of the puzzle was missing, the classification. And so, upon further examination of our tumor, we found that there were these tiny little areas showing neuropil, as well as the differentiating neuroblasts. And so we reached the final diagnosis. So I think we can clearly disregard the fact that it's not a Wilms tumor. It's a ganglion neuroblastoma, nodular, composite Schwannian stroma, rich, stroma dominant and stroma poor, differentiating unfavorable prognosis according to the International Neuroblastoma Pathology classification. A quick discussion: renal neuroblastoma has two modes through which they could appear in the kidney. First of all, it could be a primary intrarenal neuroblastoma, and this primary intrarenal neuroblastoma may result from either a sequestered adrenal rest during the fetal life or intrarenal sympathetic ganglia. These are usually associated with poor prognosis as the tumor presents with secondary metastasis at the time of presentation, and they present in an older age and at an advanced stage. The other mode is direct renal invasion by the neuroblastoma, the so-called reno-infiltrative neuroblastomas, and it is probably more common than is generally recognized. In a study by Albrecht et al., the incidence of renal parenchymal tumor invasion was 20%, about 10 patients among 49 in that case series. And generally, reno-infiltrative neuroblastomas are extensive. They have unfavorable histological features as well as lymph node involvement, and they are usually stage 3 or 4. The renal involvement correlates with large size of the primary tumor, lymph node involvement, undifferentiated histology, and end-mix status. In a marquee trial by German researchers of neuroblastoma of 1,603 patients, 29 of these, 1.8%, were those who were initially diagnosed and treated as Wilms tumor. In this study, the post-chemotherapy surgery of the mass revealed neuroblastoma, these were mostly advanced stage disease, older age at diagnosis with higher levels of LDH, ferritin, and higher incidence of NMIC amplification. It is interesting to note at this stage that our patient had none of these features. Her LDH was mildly elevated, her ferritin was within normal range, and subsequent NMIC study showed that the NMIC was not amplified. So to conclude, the treatment and prognosis for neuroblastoma and Wilms tumor are very diverse. Renal neuroblastoma carries a worse prognosis and requires intensive chemotherapy. It is important to make the distinction between these two tumors at the earliest because the management and prognosis of both is very different. Compared with Wilms tumor, neuroblastoma has, in neuroblastomas, hypertension is more common, pulmonary metastasis is uncommon, and the patient is generally sicker. So, our take-home message, if any pediatric patient presents with a renal mass, one should never rule out neuroblastoma of their differential diagnosis, even in the absence of hypertension and other clinically relevant findings, which were actually absent in our case. And finally, grossing is key. Always note the presence and involvement of the suprarenal gland in nephrectomy specimen. To conclude, I would like to thank everyone at Cancer Children Hospital for allowing me to present this case and entrusting me with presenting it. Headed by Professor Dr. Hala Taha, our head of department, Professor Dr. Najla Al-Qunai, and Professor Dr. Asma Salama, as well as our other residents and consultants. And finally, last but not least, I'd like to thank my direct supervisor, Dr. Dua Hassan Salim, whose feedback and guidance were invaluable. Thank you, Dr. Muhammad. These are our references.
Thank you, Dr. Adham. Thank you so much for your presentation. It's a great case and great discussion.